afternoon. Welcome and welcome back to you all. This is another installment of our Caregiver Speaker Series. I'm Catherine. I know many of you. I work at JABA. And we're very pleased today to be able to present about mild cognitive impairment. A very important issue, very timely, getting a lot more attention for those of us who caregivers for older adults. We were just speaking about this. It's estimated between 10 and 20% of folks over the age of 65 may develop this condition. It's suspected that maybe 7 million Americans have this condition right now undiagnosed, but there are opportunities to treat. Is that fair to say?
I don't know about it depends on the underlying, what's the cause. You gotta figure out what the cause is.
There are more strategies around these days than there used to be,
way
certainly, should the disease progress, and ways to enrich our lives in the process. So we're very fortunate to have Tanya Prachar here with us, who's nurse practitioner with University of Virginia's Department of Neurology. Has been working in this role for the last 10 years and was a neuro ICU nurse before that. So let's all welcome Tanya. Thank you.
Thank you very much for allowing me to get out of the clinic, and it's going to be so nice to be able to talk to people and not have to write a note afterwards. This is awesome. So what I've done is prepare a couple of slides. There's only about 10 slides, and I thought, because this is a Q&A, I believe, right? This is about being able to answer your questions. So I've got a couple of slides talking about, well, first of all, what is MCI? What does that mean? So a little bit of data for you, and then if I haven't answered your questions with the slides, then we can delve into and let you pick my brain to see what else I know or don't know. And I have a notebook here, so if you ask me something I don't know, I'm happy to do a little research and find the answers for you, okay? All right, shall we get started? Here we go. So first of all, mild cognitive impairment. Well, what does that mean? Mild cognitive impairment also goes by another name. Sometimes you will find it's used interchangeably with mild neurocognitive disorder. So it all depends on who you're talking to, which neuropsych group did the evaluation, and so on. But they mean the same thing, okay? There's basically three kind of components to it, if you will. So first of all, somebody who has MCI, they're noticing that their cognition is problematic. They're not feeling that their memory's as good, or they're not easily doing tasks that they were once doing on their own. So either the patient themselves noticed this, or a loved one has noticed it and is making comments about it. So first of all, we've got a subjective memory or cognitive complaint. Secondly, that when we do objective testing, whether that is like the full neuropsych eval, 3 hours long, or if that is a screening tool, we can see objectively on measures that, okay, there is something off, right? So we then have objective measures to match the subjective complaint, all right? However, the most important piece about MCI is that although there are these cognitive issues, they are not impacting a person's day-to-day activities or life, right? They're still paying their own bills, they're grocery shopping, you're driving around town, you're getting everything accomplished, living life, but you're just noticing that these cognitive issues are worrisome, okay? So that's what MCI is, okay? Now, in some of the literature I was reading through, we have normal aging, we have MCI, and then we have dementia. And there is some where pointed out that MCI can be seen as like a transition stage between normal aging and dementia, all right? So our goal, though, is to try and either prevent getting to dementia or revert back to normal aging, okay? There are two types of mild cognitive impairment. We break it down. We look at, you're either going to be amnestic mild cognitive impairment, which means that of the multiple cognitive domains that exist, memory is the one that is most affected, okay? This is, you can't remember conversations, you can't remember something that you did earlier in the day. Long-term memories are always very much intact, so those are not affected. Non-amnestic MCI is all the other cognitive domains, right? So the memory's still pretty intact. However, executive function, maybe language, multitasking, those are visuospatial impairments. Those are the cognitive domains that are most affected with non-amnestic MCI. So most likely, we'll do an assessment and we'll give you one or the other of those categories is where you'll fall into. So just a couple of numbers, just to follow up on what Catherine said. So 12 to 18% of people over the age of 60 have mild cognitive impairment, right? And then as we age, if you look at that, 25% of adults between the age of 84 have MCI. Sorry, I put a percentage there, and I did not mean to, my apologies. It's 25% of that age group will have MCI. Now, 12 to 15% of people with amnestic MCI are going to transition to dementia, all right? And we can talk a little bit about that. We'll kind of hit on why that might be coming up here shortly, okay? Now, some of these do vary, and I was, again, telling Catherine that looking at different articles in the literature, and so depending on where you look, you might see a little variability in those numbers. Also speaks to then how challenging it can be to track this information and collecting it, yeah. All right, so mild cognitive impairment. So I have it as an umbrella because basically that's how I think about it, right? It's an umbrella term. If I say you have MCI, all I'm saying is, okay, you have some cognitive problems. It's an adjective. It's describing some of the challenges that you have. All right, so now the challenge then is trying to figure out, well, what's causing that cognitive impairment? So as you can see, we've got reversible causes, and those can be, one, polypharmacy. I look at patients who come in to clinic and they have a laundry list of medications, and we're like, holy cow. So first steps first, you know, are any of these medications interacting negatively together, but also how many of these medications are affecting the CNS, have the potential to affect the brain. And so we want to minimize the polypharmacy. Depression and anxiety also can play a role and lead to cognitive impairment if not treated well. If it's left untreated, it could contribute to cognitive impairment. If you think about it, kind of makes sense, right? Anxiety in particular, if we are so anxious that our brain, let me back up, the anxiety is consuming a lot of our cognitive energy, right? So because if we're anxious, we're thinking about this, we're thinking about that, or we're ruminating about a problem or a stressor. And that leaves very little energy for our brain to then focus on what's going on right in front of us, right? So it's kind of like if you're not attending to something in the first place, then it's not going to get put in the memory file, right? So you have to, by treating the memory depression, we can help with MCI. Another important factor and reversible is sleep apnea. we now know, still a lot of studies going on about this, but at night, that is when our brain, parts of our brain go to work, and they are, it is emptying out all the trash, so to speak. But if you are not hitting certain sleep cycles because of sleep apnea, then that brain, your brain never has the opportunity to take out that trash. And then what you have then is just a bunch of gunk clogging up, if you will, all those important electrical signals that are going on. So treating, getting diagnosed, assessing if you have sleep apnea, and treating it is really important. Now, when we look at the other side here, we have what I call the neurodegenerative potential causes for MCI. And this is Alzheimer's being the number one potential cause. It's also the number one cause of dementia in the US in particular, that I can say. Other neurodegenerative diseases like vascular changes in the brain, Lewy body disease, and Parkinson's disease are just a few of the neurodegenerative that, if they're present, not usually reversible, right? We have to start looking at ways we can intervene and provide support for our patients. All right, now I did pull this up here. So because I want to go back, we said Alzheimer's is a potential cause of MCI. And there is now instead of saying amnestic MCI, right, a diagnosis, if worked up, would be MCI due to Alzheimer's disease, okay? And the reason why we want to work it up and tease out if indeed that Alzheimer's is playing a role or not playing a role is because there are new therapies on the market that can be offered, if interested, in an effort to treat the Alzheimer's. So with these new drugs on the market, a lot more attention is being brought to how we can diagnose MCI early and not waiting until much later. So the way we're going to diagnose MCI due to Alzheimer's, first and foremost, we have the neuropsych evaluation. It's going to help us better understand how is your brain working. We're going to confirm the presence of amyloid, right? So the two main pathologies involved with Alzheimer's disease is amyloid and tau, right? The new drugs on the market, they are focused on amyloid, right? They take amyloid out of the brain. So if I'm going to give you a drug that takes amyloid out of the brain, I need to first make sure that you do have it, right? So we want to do some testing to look and see if you have the amyloid. And then I put APOE status up here. APOE is a gene, right? We have several APOE. There's APO2, there's 3, there's 4, there's several of them. The one that gets the most attention when in reference to Alzheimer's is the APOE4, all right? And the APO4, if you have APOE4, then your risk factor for developing Alzheimer's is higher. It's not a guarantee you're going to get Alzheimer's, it just is a risk factor, okay? We get these alleles from, and genes from our parents, right? So you have 2 APOE alleles. And it's possible that you can have one allele that's an APOE3 and then one that's APOE4. Or they're both 3 and 3 or 2 and 2. The only reason I bring it up at this time is because if you have APOE4, it does influence the risk factors with the new medications. They come with some pretty significant potential side effects, and we want to know in advance before we give you that medication. We want you to know what those risks are. So we will do that as part of the workup as well. All right, so how do we treat mild cognitive impairment, lifestyle changes, to be honest. So first of all, going back to that list of the reversible causes, we need to figure out what's potentially causing this. Is it polypharmacy? Is it sleep apnea? We got to do and treat the depression, treat the anxiety, get those treated first, minimize medication. So anything we can do to improve our cognition off the bat, that is definitely part of it. But lifestyle changes, exercise is huge. My recommendations and that of the literature is always about 3 to 4 days a week. If you can get 30 to 45 minutes of cardiovascular activity, that is the most helpful. So getting that heart rate up. Now that doesn't mean that you can't go do weights or what have you, that is still important, but the most bang for your buck is going to be with aerobic activity, okay? Diet, so the diet is the mind diet. I brought some handouts today that have examples and tells you more in detail what the mind diet is, and gives you some ideas on how to incorporate that into your day-to-day, okay? Thinking about Mediterranean, think Mediterranean diet, to be honest. So the mind diet is a combination between the Mediterranean and the DASH diet. Cognitive engagement is huge, and it doesn't have to be you don't have to go out of your way and go and subscribe and pay money to a subscription for some program that's out in the community. That's not necessary. As long as you're staying cognitively engaged on a regular activity that you enjoy, that's beneficial. Whether it's playing cards with the grandkids, reading a book, let's see what else. You're doing your taxes. You know that's very cognitively challenging for at least for me, anyways. So those are ways to cognitively stimulate yourself. And I'm gonna pick on Carolyn here because she's a speech therapist. One of my favorite recommendations that I will do for my patients with MCI is what we call cognitive therapy, and a speech pathologist who can provide this particular type of therapy. And the way I think about it is learning, working with the therapist to improve and identify strategies that are going to help support your weaknesses. So for example, if memory is the weakness, then you're going to work with that speech pathologist to find strategies. Is it using your phone? One of my favorite speech pathologists, he uses, and Carolyn, you will in the future be my favorite too. I think we're going to have a conversation. Just saying.
I'm your only right.
All right, but you're my only one, so therefore you are the favorite, right? But he is really good about teaching my patients how to use their smartphone smartly and use it as a tool to help with the memory. He also has some, I think he's got some cognitive computer game and strategies as well to kind of help stimulate the brain. So speech pathology is a really good tool that when I can, I will send my patients with MCI to do. Okay. Social engagement, I think that goes without saying. You don't have to be, but you don't have to be a social butterfly. So I think if you told me that I had to go out and be party and go to these groups and be this social, I would probably have a panic attack. It's just I'm not naturally an extrovert, and so you don't have to be that social butterfly. So maybe going to a social program is not necessarily your cup of tea, but maybe if you go one-on-one with a friend to lunch, or maybe a small group together, and that is, you schedule that so that you're doing it like on a once-a-week basis, something of that nature. That would definitely meet the criteria for social engagement. Or you can do my favorite recommendation, which is you're killing 2 birds with 1 stone. You join a gym, right? Join the gym, because you're going to get the exercise that you need, right? And it's very social. There are people around you. Even if you're not talking to everybody, you can't. But I think just being around other people. So Yeah, kill two birds with one stone. Join the gym, guys. All right? All right, so mild cognitive impairment due to Alzheimer's, the management, again, is the same, right? It's the same for MCI if you have non-amnestic. But I did throw up here, because of the new therapies that are available, we have lecanemab and donanemab, which are the anti-amyloid drugs that are on the market. And those are designed, or have been tested rather, in patients with MCI or really, really mild stages of dementia. So again, getting diagnosis about MCI and what is underlying is, again, more important now than it has been in the past, okay? All right, and lastly, what should you do? If you have a diagnosis of mild cognitive impairment, what should you do? Well, we gotta make some healthy choices, right? We talked about diet, lots of water, gotta drink lots of water, wine, alcohol. I kind of cap it off at about 1 drink a night. I think we gotta find that balance between quality of life and cognition, right? And preserving cognition. So, having a glass of wine is something, or an alcoholic drink is something everybody likes to enjoy in the evening. Well, fantastic. Please continue to do so, but let's not get excessive. Kind of keep it minimized would be important for your brain. Exercise, we've talked about. We want to exercise. What we haven't talked about so far is future care planning, right? That is so very important, particularly if you have that diagnosis. If you don't already have a power of attorney, go get one. Go get it written, go get it finalized, get it stamped of approval. You gotta have that POA, because your family they're gonna struggle, right, and feel uncomfortable. They're not gonna know what to do, how to do, and this is your way of identifying who's gonna help make decisions for you if you cannot. And so everybody, including myself, no matter what age you are, should have a power of attorney, for sure. Start looking at a will, having that drawn up and put in place. Start thinking about, well, gosh, if this does progress, do you want to continue to live at home? Do you want to move to a continuing care community? These are things, again, for you to start thinking about and sharing that information, sharing your wishes with your family, so that everybody's on the same page and you get what you want, ultimately. The other piece is managing your health risk factors, anticipate repeat neuropsych in the future. So we're looking for progression. We want to know, is there progression? Obviously, I rely heavily on my caregivers to tell me if things have changed and in what way. So first of all, function. You guys are first line. I rely heavily on you to tell me what's new, what's different. But we also use the neuropsych eval. If we've tested you once already, then we'll do it again later down the road, particularly if I'm hearing from caregivers that there have been changes, because I want to capture that. I want to see objectively what those changes are, how significant a change is it, and then that will help us as clinicians inform the caregivers on what next steps they should be preparing for and thinking about. Managing health risk factors, by that I mean diabetes, high cholesterol, hypertension. These are all potential risk factors for developing MCI and dementia. Again, vascular disease. What happens to the heart also happens to your brain. So, managing those risk factors is a huge component of ensuring that these issues the vascular changes in the brain do not get worse. Okay? All right, so those are my slides. That is my background information about what MCI is and how do we treat it. So I'm going to open the floor to you all and lay it on me. What questions? Can't wait to hear what you have.
So it mentioned normal aging. What's normal aging? Like, we're all starting to forget things, but how do you know if it's normal?
Right. I think that's where the assessment comes in. You could do a screening with in the office. So if you go to your primary care physician and you say, I'm forgetting conversations. My wife's telling me I'm repeating things. I'm worried. Your primary care physician can do, there are multiple screening tools that can be done in the office, right? The most common one, the one that we love, is the Montreal Cognitive Assessment Tool, right? MoCA, that's the one. That's our favorite. Easily done. It's a one-page screener, but it tells us so much information. You can identify, are there visuospatial difficulties? Are there memory difficulties? Is it executive? And depending on your score on that, you could say, oh yeah, this is suspicious. You're right. This looks like MCI potentially. Let's go get a full neuropsych eval and really take a look at that and characterize if it meets that criteria. Okay. So I think first step is talking to your primary care physician and doing one of those screening tools.
But online, can you do that test online?
No. It has to be administered, the MoCA in particular, by somebody who's trained in it.
And how to interpret.
And how to interpret it, right? Yeah, because you can get a score, but you know what that score means. Without somebody who has knowledge of that, it's means nothing, right? So let's do it in a not necessarily a formal environment, so you can get some feedback. Okay. Yeah.
You're talking about these assessments. What's your opinion on the mini mental status exam?
Right. So not used very often in the clinic, right? In our clinic in particular. Now I know some primary care physicians still will break it out and use it. We see it used most often in research. So the research folks still hang on to that. Clinical trials, they still use that in their work. So the question was, I apologize, the question was, what about the mini mental status exam, which is another screening tool, like similar to the MoCA. It's an older one though. It's not as specific, I find. I find that the MoCA definitely gives really a much better picture than an MMSE will do. So again, you're going to find it, again, some of the older, probably PCPs, you may still be using it, or they'll combine it, they'll give part of it as part of their visit, but in general, it's used most often now with clinical trials. Yes?
How easy is it to get the follow-on, more in-depth evaluation, and does Medicare cover it?
Oh, my friend, yes. So the question is how difficult is it to get that full, robust neuropsych evaluation? And breaks my heart to say that we have so many people who want this that we pretty much have a year's wait for the full neuropsych. Now we're constant conversations within the clinic about how can we make this a more efficient, how can we improve this access to the neuropsych eval, but it is a challenge. So I'm sorry, I got distracted by my angst over the fact that I can't get patients in fast enough. So, what was the second part of your question?
The other question was, does Medicare cover it?
Oh, yes, Medicare will cover a neuropsych evaluation, yeah. All right, and then I'll get you, sir.
Okay. I've been hearing about like white matter. Is that the same as like an amyloid, or is it different? What is white matter in the brain?
Sure, the white matter in the brain, you have white matter and you have gray matter, right? So the white matter is white because it's got myelin sheath. It tends to be, I'm gonna get it backwards. I always get my spinal cord and my brain backwards because they're reversed. But the white matter changes that they're referring to is vascular disease, all right? So what I alluded to earlier as vascular disease is going to be what we call white matter changes It's another, like MCI, there's multiple terms to describe the same darn thing. So you'll see it written as white matter changes, it might say vascular disease, might say vascular ischemic white matter changes, you name it, that's what'll be on the report. And we're talking about brain MRI specifically is where you will see that. White matter changes, if you think about vascular disease, the brain has large arteries, of course, but also tons of microscopic blood vessels, right? Microscopic, teeny tiny blood vessels. And what's going on is that these blood vessels are not working properly, right? So they're either stop working or they're leaking or what have you. So these teeny tiny blood vessels just don't function. If you get enough of them, then you will start to see it. You can see it on imaging, on a brain MRI, okay? Now, if you have enough of the vascular changes, some people have a little bit, some have a lot, and that is the cause, like a stroke would fall under the category of vascular disease, because a stroke is a big vessel that has clotted, and then therefore damaged that area of the brain. Bring it down on a much smaller scale, and that's what causes the white matter change. Does that make sense? You follow me? A little bit.
And the white matter with the gray matter? Were you gonna?
No, the gray
expound
matter
that?
is not affected. It's all within the white, so deeper in the brain structure. So not the outside of the cortex per se of the brain, but deeper inside.
So gray matter is deeper in?
No, the white matter is. The
Okay.
gray matter is on the outside.
All right.
The conclusion of this one was the two biggest problems were exercise, lack of exercise,
Okay.
and hearing problems. Is that sort of leads to it, or is that just compounded?
No, I think it does. There is some new evidence, and I'm really sorry I did not read that. I'm not as familiar with what the new science or the new evidence is that how hearing impairment can indeed lead to MCI. It is a component and a leading factor in that. So yes, you're right, and I failed to put it up on my slides. But that's a very valid point. It is a good point. And
So
so
it is.
hearing aids, right?
Yeah.
Yeah, for sure. Also makes sense, because if you can't, again, like anxiety, if you can't hear what's going on, then how are you supposed to put it into the file, right? How can you put it in the filing cabinet? Because you never heard it to begin with, right?
And the processing, so while my major was speech pathology, my minor was audiology.
There we go.
The hearing part.
Comes
And
from
so
speech
if
pathologist.
you're not hearing it, you're not processing it, so you're
Yep.
mixing up the message in the brain. So the other thing with your hearing is your vision. So your vision and your hearing are things that you should continually get checked as you age, because not having those under control increase your falls risk.
Yep. And falls are potentially catastrophic, right? Set you down a path that you don't want to go down. So part of keeping my patients who come in, I always tell them, my goal is how do I keep them happy, healthy, and safe? Because being healthy and being safe is one way to prevent. If you already have cognitive difficulties, I guarantee that if you go into the hospital, if you have a fall or something of that nature, it's going to be really hard to get back to that baseline if you do even get back to it, to be honest. So, gotta avoid falls, do what you can. If you have a cane, use it. Yes. So that's a great question. So the question is, how do my patients get to me? How do they get to our clinic? And do they come through the ED, or is there other mechanisms? So we get, we're gonna first of all toot my horn here a little bit, because we are the only clinic in the state that provides this degree of care from the get-go, right? So I get referrals from everywhere. So we get folks from the ED if somebody does go to the emergency department because they're hallucinating and they're not making sense or whatever, and they're old enough and they're like, oh, they're gonna work them up. right? They're gonna be like, okay, what's going on? But more often than not, we think you might have dementia. Here's a referral to the memory clinic, right? So that is one avenue where patients will get to us. The primary care physician will send referrals to us, and I review, right now I'm reviewing all of them. So any referral that comes to us, I review and kind of tease out appropriate, not appropriate, 35-year-old with memory difficulties, there's another clinic that they should go to. That's not neurodegenerative, so I will not bring them in, right? Want to focus on those patients who are older and who most likely have a neurodegenerative disease. Okay, so all over the state, pretty much, we get referrals from everywhere. I wonder if you are, so the question is, Parkinson's used to be pretty much like one thing. This is you. Oh, you've got Parkinson's. You have a tremor. You have Parkinson's, kind of thing, right?
Yeah.
But your perception is that it seems to be it has other symptoms, or there's other things that fall into that category now. Is that what you're asking me?
Correct.
Okay. So no, I think Parkinson's is still very much Parkinson's, and I wonder though if you are thinking about Lewy body type dementia.
Parkinsonism, it's
Parkinsonism.
a little bit of your umbrella
Yep.
that you talked about, because there are some atypicals. It used to be, like she's saying, we had the typical, we had the tremor,
Yep.
that sort of thing, but now there's more atypical versions of Parkinson's.
Right.
So, and it is truly on the rise. I mean, that's
And I
how I
think,
spend a lot of my time.
yep, it's on the rise, and how much of that is now that we have diagnostic tools that we can now really differentiate what it truly is going on, right? And just like we have atypical Parkinson's, we also have atypical Alzheimer's too, right? That don't fit that classic, oh, this is memory, right? This is memory only. An example would be early age onset, so patients who are younger than 65 who develop Alzheimer's. That's its own kind of variant, if you will. We have primary PCA, primary cortical atrophy, which is Alzheimer's, right? But the primary finding or symptom that brings you to my clinic isn't memory, it's usually visual, right? Visual impairment. And it's usually going to the ophthalmologist, and they're going to say, because you can't see as well, you're having visual problems, and so you go to an ophthalmologist. Why would you go see the memory clinic, right? And so the ophthalmologist will send folks to see us, right? So, Carolyn, primary progressive aphasia is another variant of Alzheimer's, but there's also a variant that could be frontotemporal dementia. So the point being, and that presents with language impairment, all right, not memory, all right? There might be a little bit of memory problems going on, but the first things that you're going to note is word finding difficulties. It's going to be language impairments. So each of these have variants, and again, neuropsych testing, one, helps us identify the pattern of what's the potential cause or the diagnosis, what's going on. But we also now have, again, more opportunities to diagnose. Like, for example, PPA, as I said, could be Alzheimer's or it could be frontotemporal dementia. Two different pathologies. Used to, we couldn't. We had to use neuropsych and brain MRI to help us, we think it's this one. But now with new diagnostic tools, I can definitively rule in or rule out Alzheimer's, right? So we have some opportunities. So you are right. You are caught between a rock and a hard place. So first of all, let me reframe it a little bit. So the question is, what do you do when you have a loved one who clearly has impairments? Clearly, you see it. They can't even pay their own bills anymore. You're doing it for them. And they're refusing help. There is nothing wrong, they say. There's not a darn thing wrong with me. That is my clinic. That's in my clinic. So that is one of the big challenges. So first of all, as a caregiver, the first piece is the education. You have to know and learn that the patient with dementia does not have the insight. Okay, so it's not even a denial issue. Take the word denial out of your vocabulary, all right? They are not denying anything. They do not recognize, and it is the disease that's causing that. You, due diligence, doing your best, good intentions, trying to help, and stop, right? You, as the primary caregiver, I mean, I tell you, you have a bullseye on your back, right? You're gonna get all the heat, because all you're trying to do is keep them safe. You wanna help. But because that insight is not there, they're gonna get mad at you. Don't do that, I can do that, I can do this. So the first and foremost is one, understanding why that's going on, and that's the disease, right? Anosognosia is the fancy word for that. It's the lack of insight. They do not know they have any deficits, right? Stop. So my second one, conserve your energy. As a caregiver, you are being pulled in gazillion different directions. You're trying to manage so many things. It's important for you to conserve your energy. So step number one is stop trying to convince him that he has a problem, all right? Because you're never going to convince him or her. It's not going to happen. So you have to find workarounds, right? You have to find workarounds, and you have to kind of change your communication style, use a different language. If you go up and say, don't do this, you can't do this, you're going to get immediate conflict, right? But if you can say, well, you know, Dad, what do you think about this? Oh, you know what, I tried this and this was helpful. You're gonna have to play with it, because what works well once or twice may not work the third or fourth time, and then you gotta go back and try it again or try to find something else. Again, going back to workarounds, also recognizing and being willing to accept that there are gonna be some things that you're not gonna be able to get him to do. And so that's one. But before I say give up, I don't want you to give up. But I do think that sometimes, as the primary caregiver, like I said, you're going to get all the heat. But I suspect if I go in there, I was like, hey man, let's hop in the car. We're going to go it's time for that appointment. Let's go get some ice cream, and then we're going to hit the doctor's appointment. I am going to get a much different response than you are, because again, your primary caregiver, your daughter, your wife, what have you, and I don't have to listen to what you say. But folks always get a different response. So I would start looking at your community, your friends, your neighbors, other family members who can really do well, might fib a little bit. Because I'm going to tell you right now, compassionate fibbing, however you want to call it, but a need-to-know basis, and they don't need to know every single thing, right? So you're going to change your narrative a little bit. And then at the doctor, note, I have many patients, caregivers, who will bring me a note in advance of the visit, because we can't talk. It's hard to talk in the room, because it goes back to, like you said, they don't have the insight. So they're defensive, they're not going to listen. So give me a note, tell me what the concerns are, and I can tiptoe around and engage and try to get to that point, okay? So that you, as the caregiver, are not going to feel the heat of that trip back home where you're going to get yelled at. But I can't promise, sadly, not every physician, NP, what have you, have that degree of skill and wherewithal. So I would request either do a my chart message in advance. Everybody's got my chart nowadays, or some variation of it. Send a message to that physician if you can get access to it. That's the other issue. Yeah, but if you can get access to it, or a phone call and say, we have concerns, but please do not mention to the patient that these are concerns. That's the only thing that I can suggest, to be honest with you. It is a bit of a tricky legally issue as well. Yeah. Yes, ma'am.
You know, I'm sorry.
No, by all means.
Interesting. But what I have going through my mind right now are all the suggestions that other caregivers put out there during support group meetings.
Yeah.
Where you have, I've got this situation I'm dealing with, you're not the first one who's dealt with it, probably half the people in the room. So I would say one approach to that would be for yourself to get in the company, and you may have already done this, be like you are right now, you know, be in the company with other people who are trying to solve these same kinds of issues, because they may have some ideas for you.
Yeah.
On that theme, could you speak to our overall reason why we're all here, to caregiving?
Yeah.
Given that, you know, kind of, there may be more of a silver lining with this condition than some of the others that we all worry about, in that not everyone progresses
Correct.
to dementia.
That's right. If you look back at the data, that number, like, what was it? 15%, give or take, progress. And there's also a chunk of folks who revert back to regular normal aging.
So is there maybe a note of restraint to maybe strike here? Like for caregivers, maybe want to do too much, or can they, you know, like what would you say the role of the caregiver could look like? It doesn't have to be quite the same as someone dealing with someone with
Who has more
Alzheimer's
advanced
and
dementia.
Yeah, yeah. Because
So-
I imagine you can live your life a lot of the same ways you already do, since these issues don't interfere that drastically with day-to-day function. They're more mild.
Right. I think as a caregiver, working with your loved one, you know, going back to the very practical, first of all, the very practical piece of, let's ensure all of our POA or will, all of that, let's get sure that that's all in order, right? Let's make sure that is complete. But also, you know, reinforcing, instead of, oh, you need to do this, you need to exercise, can you do it together? I think, you know, it's going to benefit both of you. So any of these activities sometimes might be best achieved if they're done as a team versus individually, oh, you need to do this. So those are the first two things that come to my mind. And then, because then when you got that done, then go live life, right? Go travel, go do these things, because you can, and you don't want to wait and see if things do change. Then it's too hard to do. So don't let it take over and consume you and cause more worry. You should be, okay, you got it. All right, you've done everything you can to make sure life is as prepared as possible. Now go out and live it. That's my biggest, I think, important takeaway.